Fred Cerise, Patricia Kelmar, Dave Shuster. So this is meant to be a kind of rapid fire session. We're not going to give long lectures. This is the lightning round right at the start. So let's get started. Fred, to my right, Fred Cerise is CEO of Parkland Health, which is a safety net health system in Dallas, and he's the chair as a physician of the American Board of Internal Medicine Foundation. Patricia Kelmar, far to the right, is the Senior Director of Healthcare Campaigns at U.S. Public Interest Research Group, which I think everyone knows is a consumer advocacy organization with affiliates in 24 states. And Dave Shuster is the President and CEO of Horizon Goodwill Industries, a not-for-profit social enterprise in Hagerstown, Maryland, that strives to remove barriers to social mobility, including healthcare costs. So for each of you, what brings you here to the conference today?
I'll start. Medical debts has been an issue for, that I've been sort of dealing with for my whole career. I've been in public health systems my whole career, and so it's part of our work. We followed your work, Vikas, for a long time. ABIM Foundation is interested in this. And I think, I'm one of many who's struggling to find good answers for real deep systemic flaws in our system.
Patricia?
Well, first of all, thank you so much for inviting me today, and it's great to see so many strong advocates on this issue in the room today. So US PIRG is a consumer advocacy organization, and this issue actually merges two of our key campaigns, our key priorities. That is financial protection, right? Making sure that credit reports reflect accurately the information about our financial history. And trying to fix, we helped stand up the CFPB, the Consumer Financial Protection Bureau, which is really a key agency to help us prevent our credit scores from tanking because of errors. So, and then on the healthcare side, which is the area that I focus on, we've been really looking at the high costs of healthcare. We want to empower consumers to actually know real prices, to hold those providers accountable to real prices, and to make sure that we get costs closer to prices closer to costs. So medical debt ends up when we don't have good pricing and when we can't protect ourselves from overbilling.
Dave?
All right, so first of all, here's a shocker. Horizon Goodwill, not a healthcare agency at all, as you might imagine. What we are, though, is a nonprofit organization that's got about 550 employees with a team that gets incredibly frustrated when we encounter systems that take advantage of people and negatively impact their lives. So somewhere around 2015, when we started to see escalating costs in all of our traditional healthcare medical benefits plans that we were operating, we did what most businesses do, which is we started tweaking those copays, changing those deductibles, trying to make the numbers work, because as you might imagine, in the nonprofit space, we don't have unlimited margin to absorb these costs ourselves. After about 2 years, quite honestly, part of my language, we said, to hell with this. This is a bad choice. It's negatively impacting our folks. We reached out and we found a broker, and we basically started dismantling all of our traditional medical plans in favor of completely alternative solutions, really, that at this point, thankfully, work in favor of our employees to help them get access to better quality and more affordable care.
So let's just go back around in reverse order. Dave, can you just pick that up and say, can you tell us a little bit about what the success has been? What have you seen?
Sure. So we do a lot of different things, but one of the most recent and most important success I think we've had is that about 3 years ago, we added direct primary care as an option for our employees. And so in this case, it's now probably most everybody's familiar with it, but for the way we implement it is a membership fee that we as the organization pay. Our employees then who opt into that system have unlimited access to a primary care physician. via multiple modalities for whatever treatment they might need. And the reality is, when we first learned about this, it resonated and made sense that these are physicians that have completely given up on this system, right? To go back to exactly what the purpose was, which is getting to know and adequately treat the patients, and not have to deal with all the hassles and all the other things that we're dealing with there. I will say, as an alternative model, in the first year that we did this, we did not have particularly great uptake from our team members, because quite honestly, they said, "What is this?" Right? We have no idea what this is. There's no copay. How does this work? We have somebody who we can text. They had no idea. So what we did is we actually got the physicians to come to all of our open enrollment, introduce themselves, because this is part of their model now, connect with our employees, and the uptake in the last 2 years after we've done this has been substantial. And we'll talk more about some of the benefits of that a little bit later on.
Great. Patricia, in the work you've done, tell us about some successes.
Yeah, so there is one great success story that I'd love to share with you, and that's part of the No Surprises Act. You may not be aware, but besides getting surprise billing out-of-network protections, consumers also now have the right to get a written good faith estimate, and that estimate is accountable to the provider's bill. So I'll just tell you a quick story. If you're a cash paying customer, you actually can ask for and get a written good faith estimate. So Dylan called me up. He was in California, a brand new job, first insurance. He was very excited to be able to have a salary, to be able to get his pilot's license, which was kind of a lifelong dream for him. So one thing he needed, because of his past medical history, was to get an EEG for the FAA license. And because he knew it wasn't medically necessary, he was going to have to pay out of pocket. So being, fresh in the workforce, not having a lot of savings, he called around and got some estimates. And he was given an estimate for $661. And so he signed up and he got his EEG, and you can imagine his surprise when he got a bill for almost $8,000. He called me up in a panic. I explained to him that if he had gotten that estimate in writing, he would be able to hold that provider accountable through the No Surprises Act good faith estimate provisions. So he used the patient provider dispute resolution system. He showed that through the patient portal, he was given this $661 estimate. He got his money back, or actually it got forgiven, and so he took that $7,000 in savings and he used it to pay for his pilot's license, and he sent me a picture of him in the cockpit. So that's how it can work. We get upfront prices and we hold the providers accountable.
Great. Fred?
So Parkland is the safety net for Dallas County, public system for Dallas County. And one of our community health workers sent me a note a few weeks ago about a patient said she encountered at one of their focus groups, and the topic of medical debt came up. And he told the group that Parkland saved his life. And so I asked if I could talk to him, and I ended up calling him and talking to him and kind of understanding the story. And I will tell you, it's a good story for this individual. It's not a great story for the overall system. But he said, 62-year-old guy, was living in California. He was an educator. He divorced about 20 years ago, said he was intermittently pretty depressed, living in California, doing various jobs. His mother died, so he moved back to Dallas about 4 years ago. Was unemployed, living in subsidized apartment. He said that was running out, so he described it as squatting for the past 6 months. And his plan was, when he had to leave, he was just going to walk until he passed out. That's what he told me. That was his plan. Identified a mass on his head that people were worried about, said he needed to go to the doctor, but he said, I was not going to do that because debt had crushed him for the past 20 years, and he was not interested in getting into any more debt. So he had resigned to not deal with it. Eventually, he self-treated. He said he sterilized a knife and cut it open himself and created quite a mess, as you can imagine, and ended up in Parkland's emergency room. Got connected. He said the doctor connected him to a financial counselor. At that point, He was shocked to know he was eligible without having to, as he said, document his poverty, and became eligible for treatment. Ultimately, has gotten chemo. He's scheduled for surgery, but his whole attitude on life has changed, and he's like excited. He's positive, and it just shows how much that issue was weighing on this individual, and the relief of that, how he now has a new lease on life. Great individual story, but highlights the problem, right?
Yeah, I was going to say that's a definite feel-good story, and then points to all the different places in the process that need attention. So we know things are possible. We know that certain individuals, certain kinds of leadership, certain kinds of practices can have a huge impact. So for each of you, what's a key impediment, or is there a thing that's really most frustrating as you think about this issue from where you sit? Dave?
So you can't be disruptive without hitting speed bumps, right? I mean, these things happen. So for all of our folks that don't opt for direct primary care, and then for all of our major medical services, we use an open network Medicare reference-based pricing model to pay all of the claims, which we're based in Maryland. And if anybody's familiar with healthcare regulation in Maryland hospitals and Maryland providers generally sort of get this because we've got pretty good pricing controls in Maryland. However, we also have employees in Virginia, West Virginia, and Pennsylvania. The systems that we interact with in those states, when they first see this, like, what in the actual are you talking about? Is this even insurance? Like, what is this card? It's not. It doesn't have a blue thing on it, right? We don't know what this is. And so what we end up doing is getting into protracted arguments with usually it's the major systems. Small providers, we usually are able to find somebody in their billing person and talk with them. But our claims adjusters end up having to go round and round and round with these major medical systems still to try to resolve these claims. And as everybody knows, meanwhile, we don't get the collections notice, right? As the employer who's working on behalf of the employee gets all that scary paperwork in the mail, and all that, and they start freaking out, and they start pinging all of our team members about whatever the $60,000 bill is that I'm getting that I can't pay. What are you guys doing about it? The good news is that we have now at this point a protocol internally where, as to borrow somebody else's language, never pay the first bill, right? So send that to us. Bring it to us. We're going to take care of it. We realize that this is stressful and anxiety producing right now, but we got you, and we do. And every single one of these, we ultimately end up settling in some capacity. Twice, I think we've had to get lawyers involved to deal with it. And so, as you'd imagine, there's still a lot of frustration on our part in that one, because that goes back to some of this pricing and lack of transparency and all of this billing. But we also did within this find a positive solution, and that is that most of these systems ultimately got tired of us eventually and were willing to direct contract. So for most of them now, for all of our folks, we have negotiated sets of pricing so that we've actually eased that pathway. It also helps that I've recruited 2 of the systems to have members on our board of directors, which once they find out what's actually going on, like, wow, why are we such a pain in the you-know-what to everybody else in the world? So, I think just from the employer standpoint, you can do all of the things, and it still causes challenges for the folks that are at, the patients and the folks that are under our care when they actually go out and still interact with this system as it exists right now.
Patricia?
Well, maybe I'm kind of cheating a little bit, but I would just say the whole billing and payment system is the biggest impediment, right? From the beginning with the prices, right? Our insurers, the employers aren't able to really work to get in a consolidated system a decent payment, a decent negotiated rate. There's a lot of cost shifting, right, for co-insurance, co-payments. And then the claim denials, right? We're seeing AI is denying claims, the claim denial system for the consumer, the patient who gets that denial, trying to figure out all the paperwork they need to file. And they're left arguing whether or not this was medically necessary. I mean, what kind of information does a patient have, right? So, and the provider steps back and say, hey, that's the insurance company's problem. So I think it would be the whole system in general is frustrating. And it ends up meaning that consumers either have a really large bill that they have to pay in 90 days. They might be marketed extremely high medical credit card in the doctor's office or on the hospital website billing page. And if there's an error, there's a good chance it's going to end up on their credit report, and then they have to decide, should I just pay it to save my credit score? So I think it's just the whole billing and payment system that's a huge frustration.
Yeah, so I think you're going to hear a common theme today. And in addition to cost, it's the complexity of the system and the fragmentation of the system. So from the hospital perspective, when we want, which we desperately want to simplify this process on how we deal with it, the fragmentation of the system makes it very difficult. When we see patients, what insurance do they have? What are those copays? Many of them have very high copays. Do your discount policies, can they apply to those copays? Each one of those has to be a negotiated thing with the various insurers. Are people in network or out of network? For us, we have a county-based program that provides a lot of support for people in Dallas County. We get a lot of people from surrounding counties. Are they in county or they're out of county? If they're out of county, they're not eligible at the same level that they are if they're in county. Are they eligible for other programs? Did they apply? So if they're eligible for the exchange, did they apply for the exchange? Because as a county program, you want to be the payer of last resort. And what happens if they didn't apply for that and they need care right now and they're in front of you? And so the fragmentation of this the system makes it incredibly difficult for patients to navigate, and even for provider systems that are trying to simplify this. It makes it tough to put one program in place to address the problem.
So a real challenge is the complexity. I think we all know it. We all hear it. Anybody who deals with the system, either as a patient or a clinician, knows how weird it is, weird and complex it is. So how do we change this? How do we fix this? I mean, Dave, your day job is not fixing American healthcare, is it? So, but I guess I would still ask you, if you thought of a solution, something in your day-to-day as you grapple with this, is there one, two, or is there anything you've seen either at a policy level or as a practical level or some other way that you would embrace?
Sure. To your point, 10 years ago, I never thought I would end up knowing as much as I do about the entire healthcare industry. And unfortunately, this sentiment will probably resonate. The more I learn, the more disappointed I get, unfortunately. So from just a personal instinct standpoint, part of me just wants to sit up here and say we should dump the whole system and start over, put the mic on the floor and walk off the stage. But that's not really a viable solution. And also, I will acknowledge I only know what I know, and it is complex. But what I will say is I'm going to go back to the direct primary care for a second, to sort of that simplifying the system that we just talked about up here, especially. One of the things that we have learned in the past 3 years about this is that, interestingly enough, our ultimate claims cost has gone up some as a result of this. But here's what happened. As a Goodwill, we're a workforce development agency. We work with a lot of folks that are in lower income brackets, quite honestly. These are folks that until they came to us and were offered direct primary care, neglected their health because they were very scared of the cost and the not knowing how to navigate the system and whatever the case may be. So now they have access to a primary care physician who says, well, wait, we really need to treat this thing that maybe if we'd gotten this 10 years ago wouldn't be what it is now. But now we're going to take care of it. Where we've actually seen most of that increase, honestly, is in our pharmacy side, where we end up with folks that are now on various maintenance medications for conditions that those physicians have identified. Now, I'll also tell you, we completely dumped all traditional PBMs for this thing. We use a concierge pharmacy system that, quite honestly, most of our employees get their meds for free. There's some that we end up still paying for, and we actually are able to incentivize our employees who sign up for that program with a cash bonus, actually, when they're willing to put in the extra effort on their part to qualify for it. But I think my solution, at least, would be, from an employer standpoint, to seek out and engage with direct primary care physicians as part of your overall medical benefits package, at least right now, because they're out there. They're more than willing to do the work and help solve some of the challenges that we're talking about here, at least at that initial care level. And the reality is that we know that if you get these things early, right, the downstream cost and the downstream need generally decreases through preventative medicine instead of having to deal with it later on when it becomes an absolute crisis. So that would be what I'd suggest.
Patricia.
Well, besides solving the root cause, which is high prices, so that will be easy. We'll do that tomorrow. We should really be giving consumers, in the meantime, really strong tools to know and hold accountable providers for any care that we're scheduling in advance. We also need to solve the problem of really complex medical bills and the difficulty of claim denials. And then finally, we need to get that medical debt off of credit reports. This is not an indication of a consumer's unworthiness of getting future credit. This is a situation where people have gotten sick or they've been in an accident. And unfortunately, we, although we've already won that, it looks like it's really not going to go into effect. So we'll still have that on our plate and list of things to do.
Yeah. So first, I love your direct primary care, and that sort of intensive primary care model is a great approach. We've seen the same thing. However, as we've pushed more people into that model, our costs are going up too. I expect that that's going to level off and come down. But just like you identified, we're identifying people with chronic disease. The GLP-1s are just, from a cost perspective, have really been a killer for us. And we're having to relook at that, even though we're covering them for people that have, other chronic conditions besides just covering it for obesity. It has been a big issue for us. But I think that's the more sort of primary care intensive you can get to manage things. I think it's a better solution. I'll give you two perspectives. One is kind of I think we're going to chip away at this in a bunch of different pieces until and it's hard to just ignore the fact that our system fundamentally is not going to solve this problem as long as we have this market-based variable coverage that just does not address the entire population, and it's got serious gaps in affordability and in coverage. And as long as we're relying on that to solve the problem, we're going to continue to struggle sector by sector on how to cover it. And so, at a high level, we've got to be able to address a common solution for everyone. First dollar payment for people, whether it's a public option or whatever you want to call it, but something that covers everybody. As long as we look to the sectors, which I think we have to do. Look at the hospital sector, look at the payer sector, look at the providers. We need to do that because there's a lot of work to be done in those spaces. But it also creates an opportunity to point the finger to other areas. And without a consistent set of rules on how to address this, you're going to squeeze here, that's going to bulge out over there. And so the real answer is some fundamental change in how we provide coverage in the country. Now, from a practical perspective and what we can do, and I look at our sector, I think simplifying things, a common application for financial assistance that everybody could use, a common set of rules, eligibility, what are the expectations, reporting requirements, things like that, rules around you can't sue people, you can't report to credit agencies because people get sick. Those things should not be allowed. Max pricing for unfunded, uninsured people that's, maybe tagged to Medicare or something like that, but put some kind of restrictions on that. Things like community benefit expectations across the board. Hospitals have this expectation, but then it's incredibly vague on how do you fulfill that expectation. And so giving some more direction and guidance on that could achieve some consistency, across the industry. And I think, I may be optimistic, but I think you would get more sort of participation and responsiveness if there was more clear expectations of what hospitals need to be doing in this space. It's a piece of the overall solution, though.
Thanks. So I think we're going to open this up to questions. And just to rile things up, let me give you some of my ideas for solutions. Going back to the drivers of costs, if we go down that checklist, I think we need much more aggressive antitrust enforcement. I think we need a much more aggressive FDA, not one that is a rubber stamp for kind of stupid and very lousy clinical trials. So I'm kind of with Marty McCary on that one. No question that, let's just call it what it is, Fred. We need universal coverage in the country. And I'm with Joe Rogan. It should be socially funded. Come on. I think that is a key part of a solution. We're going to get there one way or another, but it's going to take more or less time in the conversations about how much suffering on the way. But beyond that, I think Medicare for all, without some understanding of the volume-driven nature of our current system and how deeply embedded that is, Medicare for all ain't going to be sustainable. So you are going to have to go to budgeted systems, capitated payments, direct primary care, an overhaul of how you deliver care in that way and how the funds flow. And let me just say, that can't be done by intellectual elites. This has to be done as a process democratically in the country to understand. And I'm on record as saying, if the American people in their wisdom want to spend 100% of GDP on healthcare, it is their sovereign right. But I also believe that nobody's that stupid. And in fact, we will get some real common sense about what the limits are for healthcare spending. But people have to be involved in that. Otherwise, you're going to get the backlash that's inevitable. From a policy point of view, and I'll keep talking until there are questions. So do we have questions? Okay, good. The last thing I'm going to say is we got to move beyond, clinical effectiveness for coverage decisions. We got to look at cost effectiveness. It is just crazy when you're at 20% of GDP that you're not going to think about what the cost effectiveness of a new treatment or technology is. So if Congress wanted to do something radical and major in a way that would solve things and probably unite left and right, I think, that would be one of them. Let's actually start looking at that before we start paying for proton beam therapy for stuff that really doesn't need it. Or when we have, 5 bariatric surgery programs in one town. I mean, I could go on and on. I'll stop.
Hi, good morning. Adam Fox with the Colorado Consumer Health Initiative. I was a participant in the work groups here for the project we've been working on. Sort of 2 questions, one for Fred and one for David. For Fred, I think you called out a lot of things that would be really helpful, and sort of to Vikas's comments, you didn't comment about Medicaid expansion, which is lacking in your state. And so I'm curious if you can expound on a little bit on that front. Obviously, there's the federal context that we're all having to bear in mind, and the potential cuts there, which would be devastating and explode medical debt. So hoping you can speak just a little bit on that front. And then David, I think it sounds like your model is a little bit different, but I think what we see in Colorado oftentimes with direct primary care, don't disagree with it in principle by any stretch. That's how it should be structured. That's why we've put first dollar coverage in the Colorado public option plans that we have in our state. But I think what we see is oftentimes direct primary care is not paired with major medical. It's not sort of built in to the overall health coverage. And when we're talking about medical debt, hospitals are a huge driver of that. It's less the primary care side of the equation. And so what we see is often patients and consumers, if they are pulled into direct primary care, they are either doing that in lieu of major medical or they are paying for both. And so it ends up adding costs when it should be part of their coverage. So I'm hoping you can speak just a little bit about that and how you are thinking about getting direct primary care as an integrated element?
Well, so for Medicaid expansion, so Texas is one of 10 non-expansion states. I don't get to make that call. If you took a popular vote in Texas, people would support Medicaid expansion as they do across the country. It's the state leadership that has not supported that. And as you know, that is one of the things that really can make a difference in terms of this medical debt issue, right? It just does. Texas, we have probably 5 of the top 6 or 7 large counties in the country that have the highest amount of medical debt, and it's not coincidental. I mean, it is related to the fact that we do not have Medicaid expansion. So, the cuts that are being talked about right now, who knows where those things will land, but that's certainly a threat to all of us. The more that access there gets cut back, but to your point, it is one of the things that that all states could do, state and federal governments, to enhance access to Medicaid, because that will have a real impact on individual medical debt.
So in our case, we opted that those employees that sign up for direct primary care, they have no cost out of pocket for that ever. We actually pay the entire cost for those folks. So that's sort of the first threshold in keeping that cost for them down. And quite honestly, it comes back to sort of math at that point. We realized that the membership fee, so to speak, that we would be paying for that was in fact cheaper than having to adjudicate claims if we sent them through the other side of the house. So it saves all of us money in the grand scheme of things, the organization as well. I will say we use a lot of integrated tools when folks end up having to navigate from the direct primary care to some kind of major medical thing. The first thing is that all of our primary care physicians will work with the patient to attempt to find particularly depending on what the circumstance is, and we also have a couple of referral tools for this, to find locations that have the highest quality outcomes at the lowest cost that we can refer folks to. And so when you opt for one of those, it dramatically reduces what your patient contribution for the cost would be if you choose one of those options. You can certainly go anywhere you want to. We're not restricting folks' choice in this case. And even if you don't choose one of the recommended places, when you compare our plan design at this point, because of the lower cost model that we're using to any other place, we have the lowest copays and the lowest out-of-pocket deductibles of just about any plan that we compare ourselves to anywhere else. So there are levers within the way that it's designed where we're able to sort of manage that entire cost for the patients when they're seeking care. I hope that helps clarify a little bit.
Well, believe it or not, we have to move on. Thank you all. This has been a great kickoff. Hope it whets everybody's appetite. Let's keep talking.